Brad Turpen, how are you, sir?
I'm doing great, thanks.
Good. You are the CEO for the Emmett Hospital. You and I got connected because I'm really concerned in the state of Idaho about women's access to healthcare. And some people feel that pretty much everybody I talked to has said like, okay, this is a complex issue. And it's like, okay, great. And I started peeling back the onion with the legislation that rolled out from the trigger law and then the revision to that law in 2023. Those are important conversations. And obviously it's not like I solved everything, but important conversations. But what came from that too was, hey, look, even if we change the legislation, there are problems with offering healthcare in rural parts of Idaho that will not be affected or not gravely be affected by the change in legislation. The Emmett Hospital had to remove its labor and delivery unit recently. And I initially thought like, oh, well, we lost all these OBs. Like that's probably a result of the law or the, exodus of the 25% of the OBs in the state of Idaho. And you and I connected. You're like, nah, that's not, I mean, like maybe, but not
for us.
Not for you. Mm-hmm. Talk to me about this. Give me the history, background, your experience at Emmett, and what led to closing the labor and delivery.
Yeah. So, Valor Health is our organization name. We're kind of a micro health system. People refer to us as a hospital, but we see a lot of patients on the outpatient side more than in the hospital. But the labor and delivery piece specifically, I mean, I joined the organization in 2015 and it was being talked about at that time. Labor and delivery, as we talked about before, it's a service that you do and you do well and you do all the time. This is a 24/7 and it takes a lot of infrastructure to be able to offer that to women and moms in your community. It's not a, we can do it sometimes or we can sort of do it. You do it, you knock it out of the park, or you don't do it. And not that we were, we were having good results, but the infrastructure that was required to do that, and frankly, cost, and I can talk about cost later, to hold that up in a rural environment, especially for us, we're in a unique situation where we have pretty good access to Boise, Meridian, Nampa, and other larger facilities that have maternity wards. They have NICUs and things like that. So we didn't have a big percentage of our moms in the community choosing to deliver their babies at Valor Health. Probably 25-30% of the births for the county every year was in kind of the 200 per year range were coming to Valor Health. And for those moms that could deliver there, they had great experiences. They loved kind of that personal touch and that hometown feel and all of those things. And we're always impressed at the outcomes we could produce, even at the small size we were or are. But what we got up against is just a really difficult decision organizationally. So, and we can probably get into it later, but it is really, really difficult to stay in the black in rural healthcare. We have predominantly Medicare, Medicaid patients. We get reimbursed at levels that don't even cover our costs. So
explain this to me, because and I don't mean to interrupt, but I think this is a really fundamental, like I don't quite understand this nuance of reimbursement. Representative John Vanderwoude came in. He's obviously the chairman for health and welfare. He came in months back, had a great conversation with him, but he kept saying like, well, there are problems with reimbursement. I'm like, what do you mean? Like, I don't what are you saying to me? Like you give a drug and it costs you like $100 to give it and you only get like you're going the black. And again, help me understand that. So when you're saying, and by the way, you keep saying we can get into something later. We can get into it right now. I got nowhere else to be. I got coffee. You got your black tea. Like, yeah. Let's go. Like, what do you mean when you're saying managing the fiscal responsibility of a rural hospital is difficult? What does that mean?
So generally in the rural areas, more patients are on government, what we call our payer mix. So payer mix is that Blue Cross. That's a commercial source of reimbursement. Medicaid, Medicare, those are government sources of reimbursement. So typically in rural environments, there's good data out there that, there's a higher percentage of population in those communities that have Medicare, Medicaid as their source of health insurance.
Okay.
Whereas in a more metro area, more people have commercial insurance.
And is that just the nature of the employment base and things of that nature?
Typically, yeah.
Okay.
It's just the nature of, kind of who
Age,
lives where, what
average ages and things of that nature.
age, working status,
Okay.
all of those things. Um,
Can I tell you something real fast?
yeah.
I'm traveling over the summer. You just said I'm traveling over the summer with my family. We stopped somewhere to get gas, and then we're like, let's pull around the corner. It was like we're in between Redfish and Rigby, where my wife did this water polo tournament. So we're like somewhere in the middle, right in the middle of nowhere.
Yeah,
it's great. Stop in this little town, and crop dusters going by and stuff. Like awesome. We're making sandwiches in the back after we get gas for our kids. Keep going. And my wife loves me. She's like, check this out. Check this out. I look over, and it's this woman who has got to be like 80. And she's on an ATV, a four-wheeler, at the stop sign, like gnarled. She's got these old weathered tattoos on her calves. And she just guns it. I was like, oh, wow, that's awesome. We keep making the sandwiches. And I kid you not, man, as we're shutting the trunk 3 minutes later, she was like, oh, my God, turn around. I turn around, and this lady's coming the other direction with a 40-pack of Miller Lite at her feet. She says,
it was a beer run.
It was a beer. She had to be 80. And this was like 1:00 in the afternoon. I'm like, it was Thursday. It was a Thursday.
Oh my gosh.
I was because it was the day the Redfish fire started. We had left. So it's Thursday at 1:00. This lady's on her four-wheeler to go do a beer run. So when you talk about age and like employment status, it's like she was not going to work at that time of the day.
Yeah. And it's amazing. I mean, those rural communities, they're so tough. They're so connected. They really take care of each other. But yeah, I mean, a lot of them, from a health insurance standpoint, they're reliant on government sources. Yeah. So what that means for us, then that higher percentage, and when I talk about reimbursement not covering costs, so we have a really complicated system in healthcare. I mean, in fact, my senior in high school daughter was asking me, why does healthcare cost so much? And so I tried to explain to her what this system that we've created, and you've got all these different entities and all these codes, and it's overly complicated in my opinion. But for the services that we deliver, we'll send a claim, and we'll say this is what our cost was.
Sure.
And we'll typically discount that. We have contracts with payers, with Blue Cross. It might say, we'll accept a X% discount, and, we'll agree to that price because that helps us give we have access to people in your network, and that's all pretty standard. But those reimbursement levels are significantly different than a Medicare and Medicaid. And we get, I think Medicaid is 57 cents on the dollar. So every dollar that it costs us to deliver, and that's, you start from the building, right? Building costs, personnel, supplies, infrastructure, equipment, insurance, pharmaceuticals, all those things that come in to deliver a service, there's a cost associated with that. And so we'll say this is what we'd like to be reimbursed, and we get significantly less than that. The one great thing about critical access hospitals, we have a cost-based reimbursement model, and every year we do a cost report, and they come in, they kind of see, and there's other mechanisms. There's upper payment limit and DISH and UPL, DISH. We love our acronyms, but
I can see that.
There are systems in place that are intended to try to keep us whole. The downside to that is, like as an example, we're in a situation right now that will connect back to labor and delivery. We had to make some significant changes around our cost structure because we were just upside down. We were 8 months. If we had kept burning through cash the way we were burning and not made any changes, we would have closed the entire health system in 8 months. So we had to make some really, really difficult decisions and some big changes. By virtue of doing that, we really improved a lot of our cost structure, and we just kind of went tip to tail and everything, and try to figure out how can we be more efficient in the services that we deliver. And we actually did so well that Medicare decided that they had been paying us too much, and so we had to write a check back. And so we sit at this kind of negative 2% margin on Medicare because we can never make too much and we can never make too little. The great thing is it helps critical access hospitals like ours stay open. But it also means that the only way for us to really grow, and, we have this saying, some people say, no margin, no mission. But what that really means is where there is no margin, there can be no mission. Where there is no additional revenue generated, we can't do things like we've just been able to do is, upgrade our MRI system, invest in a pharmacy that can mix chemo drugs so we can start to deliver chemotherapy for oncology patients in our community. But because of that system that keeps us right at that basically really, really thin margin, we have to look to the commercial side to get that reimbursement and be able to make those investments. So that was a little bit of a rabbit trail, but
no. That makes sense. So you really need that private commercial insurance to develop the margins for your hospital, because the public Medicare and Medicaid are not going to produce that revenue.
Correct.
Does that mean that you have to drive up the costs for the other? And I know that might be like a rough question to ask, but does that mean that like you essentially have to make things cost more for the commercial insurance side of it to overcompensate for that margin on the other one?
We don't necessarily drive our costs up to do that. We do try to, and I mean, you got to you have to make a return. Like you can't be in the black. Like I said,
red.
Where there is no margin, there's no mission, right? So we don't necessarily drive our costs up, but we do try to generate. We will provide services to everyone.
Yeah.
We're obligated and morally compelled to just take whoever walks in the door, regardless of payer source, and we take care of them. Then we figure it out later. But we do things, and I think probably all healthcare entities do this, to try to find out, well, where is the source of revenue? Where are those commercially reimbursed patients, and how can we, what services do they need? And let's grow overall, but let's make sure we are capturing that.
So just to make sure that you have that, you have the items they want. If we consider medical services items, it's like, look, I'm selling the things that you want to buy.
Yeah.
Just buy them here, and they're going to cost the same as you would buy them somewhere else. Like I'm not going to be gouging you. Just buy them here, right? And figuring out, okay, what are like the top 10 services or things that people are looking for in a hospital that we could get that commercial insurance reimbursement from.
Yeah.
Look at that. We figured it out.
There you go.
Great.
Yeah.
Great. I put it all together.
Yeah.
So that sets the stage for, okay, you're kind of riding this razor thin line of you're being pulled down to some degree, financially slightly negative by the Medicare and Medicaid, which is a larger portion of your overall client population, your patient population, than normal. So you already have a negative in a larger portion, and then a smaller portion of the normal reimbursement people. But that's this setting the stage for, okay, we're not swimming in a lot of money. Like we don't have a lot of options to just throw good money after bad, or to provide services that are underutilized or undervalued by our community.
Yeah. And we got to that point, and just for statistics sake, people are surprised to hear when I talk to my colleagues around the state, around the country, that mix for us is 75% government payer, 25% commercial. Most systems are far, far beyond 25% commercial. So just think about that. If you're running a business and 75% of your customers pay you less than it costs you to deliver that item.
Oh yeah.
It's
Oh yeah. I spoke with the chief of EMS down in Canyon County, because he was like, listen, as an ambulance service, right? It's a paramedic guy. We have a lot of older people that we obviously go and pick up. He's like, in an ambulance, of course, like you're going to be, somebody has a heart attack. It's like, you don't meet a lot of 5-year-olds that have heart attacks. These are like 50, 60, 70, 80-year-olds that are requiring these emergency services. And as you're articulating, it's like a lot of them are on government-based insurance, and we take a loss. He was like, we take L's all day long with these things. It's like their reimbursement rate is something like 50% of the actual cost, and the reimburser doesn't care. Like, it's not my affair. I'm giving you $500. If it costs you $1,000, if it costs you $2,000, doesn't matter to me. You're taking this write-off, and they're funded by the state right, through property tax and through reimbursement, and they're just getting hosed. And that's his big point, which is like we are inherently at risk of being unfunded because so many of our clients or patients or people that are picking up are getting reimbursed, and we're getting reimbursed at a loss.
Yeah. Yeah.
It's brutal.
One thing that's interesting for us is we are county owned, but we don't receive any tax dollars. So we essentially run independently from a financial perspective. We have to, and a lot of hospital district hospitals, county hospitals in the state, across the country, the taxpayers in the community will offer some sort of supplement to cover some of those costs, like holding up a labor and delivery program. We don't have that in our community, so that puts us in a situation where we really have to be really, really good fiscal stewards of what's going on.
So you're in this situation. When did you start looking at labor and delivery as something that, may not be making financial sense? And were there problems with it that you were addressing before you got to that point? Because obviously it's like people can put up with a lot of problems as long as they're solvent. But the second the money starts drying up or they realize like, oh, this is we're done so, right? So were there problems that you guys were trying to address with staffing or things of that before the financial viability came into question? And then how did that all play out?
And I don't want to characterize it as a financial decision because it was way more complicated. I mean, this is a complex system, lots of different factors. But it was always a challenge. And I don't know a rural healthcare system that isn't challenged to deliver labor and delivery services. We talked a little bit before, just the staffing alone. You think about on the floor in the labor and delivery unit, at all times we have to have a labor and delivery trained nurse, L&D nurse. And so we have to attract those folks to our hospital. In our hospital, because the overall volume's low and the birth numbers are pretty low, that person, they don't get to just wear their L&D nurse hat and just sit around when there's no mom there. They're working the floor, they're working the ED, they're doing all kinds of different things. And then, if there's a delivery, they can take that on. For nurses who were really interested in delivering babies and being kind of an L&D nurse, that's not an environment that they want to work in. And the flip side of that, you have nurses they'll say, well, I like ED, I'll do a little floor, but I don't know, I'm not sure I want to get into that L&D stuff. I'm not really trained to do that. So it just makes the staffing, overall, it's hard to recruit nurses. We know that we have a nursing shortage nationally. In the rural environment, it's even more difficult because they have to wear a lot of different hats. And so a lot of times we'd have nurses that might get into doing deliveries and really like it. And they'll say, I'm going to go to St. Luke's. There's an opportunity for me to work in the L&D unit at St. Luke's.
Oh, my entire shift. I don't have to
all
do
day,
anything
every
else.
day.
I love this. This is what I want.
Totally. So that became really difficult for us from a staffing standpoint. The other piece is just the infrastructure around it. People don't understand. And like I was saying earlier, you don't sort of do L&D. You do it and you do it well. And what that also means is that you're ready to go to C-section at a moment's notice. Something goes south with that delivery, boom, you're in the OR and you're ready to do a C-section. Well, if you think about all the infrastructure around the OR that's required to do that, so you need to have a physician, and we had willing physicians, although we lost a couple of physicians just through retirement, and so that call burden became, maybe instead of once every 4 days or 4 weeks, it was once every 3, then once every 2, and so that wasn't necessarily a concern. My hats off to the physicians who were willing to do that. But you start talking about central sterile techs, you start talking about pre-op nurses, post-op nurses circulating. You got to have this entire surgical team ready to go 24/7. And that became another, a real challenge for us to keep people who were willing to do that. So you got the surgical side, you have the L&D side, the physician side, you have anesthesia, just all of these pieces that have to come together to sort of put out a board on our front door that says, we deliver babies, we do it well, we do it safely, all of those things. So lots of infrastructure. The other piece there is just, it's just risky. I mean, that's one of the most precarious things you can be doing in medicine is delivering a baby, and it's it's emotionally charged and stressful, and everyone wants to do it great. And when it goes well, it's joyous.
Nothing better.
Oh my gosh. And that one of the, there's some things that have made this really difficult. You have to make a decision operationally, financially, and all of these things. But one of the most difficult things to deal with is our physicians. This is a source of joy in their life. And, the numbers around physician burnout in our country are staggering right now. I mean, it's a real issue. And so for our physicians specifically, this was like a little bucket fill. They might be dealing with end of life issues. They might be dealing with a difficult diagnosis, all these things. But now they get to work with a mom and they bring a baby into the world. And that just, that fills their bucket for a while. So this kind of takes some of that away. Although our physicians have found ways to work with other facilities in neighboring towns to deliver babies, so they can provide the prenatal care, the postnatal care in their clinic. In our clinic, there's other physicians in our community that do that, but the delivery itself happens somewhere else.
And then the physician can travel to that location.
Yeah. And
that's great. So you can still have the relationship, the prenatal care. Wow, what a solution. Like, who came up with that? That's great.
It is a solution, but I don't want to, it's less than ideal.
Yeah. Okay.
Because the mom, the family, they have to go. Sometimes they'll go and maybe get a hotel room the day before or something like that. The physician would have to, the babies don't come on a schedule, right? So they're in clinic. They've got 20 patients scheduled that day. It's 9 a.m. and all of a sudden mom says, "I'm going. Will you meet me there?" And so logistically, where they could just previously walk across the parking lot,
right?
Now they have got to get in the car. They've got to close their clinic, get all those patients rescheduled, go and, be at St. Luke's Nampa or whatever it is and wait for that delivery. So
gosh, man,
you get the outcome, the outcome, but it's a significantly more complicated process to get there.
Yeah. What I was thinking that is a great idea. It's a great idea in the absence of having a full suite of offerings at your hospital, right? It's better than not having anything. So it's like, imagine, I mean, I have never had a kid, but we have had 3 boys, the wife and I, and, thinking about traveling really far for just, normal prenatal care or just checkups and things like that. We also had one situation with one of our births where we had a lot of false alarms that were like really significant false alarms, but they were false alarms. And it was, over a period of, I think, like 4 or 5 days that, we were going and calling in the troops, like, it's like, we've got other kids at home. It's like, call them in. And, I felt horrible that like people were coming in, but it's like, this is what you have to do. This is part of it. But we were only like 10 minutes away from the hospital. Right. Like we were literally like 5 minutes to the freeway, 5 minutes down the freeway, we get off and then, there it is. If we had to drive from Emmett to like Nampa for a bunch of false alarms, that is not a great idea.
Yeah. Yeah. Well, and we do as much as we can. So we have ultrasound in our hospital.
You got to figure out if it's
moms will come over and they'll get their ultrasounds. Yeah. We've have some fetal monitoring that we can do in the clinic. And so, yeah, as much as we can on that outpatient basis, everything, if you take the whole process, we can provide all of that. If you just think about that delivery section,
right,
which is really important,
right?
But
that's kind of like that's the big enchilada,
man. Yeah, we're doing everything up to it and everything after. But that decision to stop providing that service, really just kind of covered that section of it.
Gotcha.
And again, just really difficult. I could go in so many different directions about that process. So we're county owned. We have commissioners that appoint a board of trustees. These are community volunteers. They're typically, civic leaders. They're business owners. Just incredible servants. And we had to make a decision that was going to be unpopular with a portion of the community, and really part of the journey has been trying to help them understand why that it was, it's not easy decision this is going to be great for everybody, and it's a decision that's easy to make. And, the alternative is, clearly bad. It was not easy to make that, because a lot of people are going to be upset. It's a service that, those moms who did, like I mentioned, who did deliver their babies, they had a great experience, and they talk about it in town, and they share that in the community, and they're proud, maybe they were born there and they delivered their baby there. I mean, it's a long legacy of delivering babies there. So not all, that was not lost on us as a board. But it just really came down to, can we sustain this program, and can we staff it? We got to the point, I talked about the labor and delivery nurses. We got to the point where we were on what's called intermittent divert. Divert is a term where we kind of say, hey, this is typically a service that we can provide, but right now for some extraneous circumstances, we can't do it. We can't do this right now. And so, you'll have to, if you're emergency, you're going to have to bypass us and go to the next facility or whatever it is. So we were in a situation where we had to say intermittently, hey, we have a labor and delivery nurse this week. And we were to the point where a lot of these were traveling nurses. And that's another topic to explore. Very, very expensive way to staff. And so, hey, we got a traveler this week. If any moms come in, we can do it.
Yeah.
But that traveler is off from this day to this day. And so if any mom come in, we can't do that. Or even, we had times where a central sterile tech was the reason that we couldn't open up the OR, have the OR ready. And that meant, well, we can't go to C-section. We can't go to C-section. We can't deliver a baby. So we were just in this situation where it was like, we cannot, this is not a tolerable thing for us to do, to say to the community
that you can do it. You can do it well.
Sort of do it.
Yeah.
Sometimes, you know, if your baby decides to come at the right time, then you're good. I mean, that's just, and again, morally it just doesn't feel great.
Right.
You do it well, you do it all the time, or you don't. And so that was kind of where we came up. And it really, all of the discussions that we had and all of the wrestling with the information, when we got to the point where we just could not staff it, we just said, we can't do this anymore. And, we mentioned the St. Luke's and, West Valley, St. Alphonsus. I mean, they have been amazing to work with. They've been really supportive. They're very supportive just across the board in lots of different ways. We transfer patients and all that. But when it came to this, they understand the importance of this to people. And they've offered solutions. Like I said, our physicians, have privileges at these facilities. They can take care of moms. And so they've been really good partners. So even though we don't have the ideal solution, we have a good solution for those moms in our community.
There's so much here, right? There's so much obviously that led to this. Do you think that there would ever be a path back to being able to provide this if there was like a campaign within the community to say like, hey, look, deliver an Emmett, support Emmett, right? Because, hey, look, if we're only grabbing 25% of the deliveries from, families that live within our boundary, there's no, like, we can't, it's like Noah's Bagel, right? Like if people only buy bagels, once every 3 weeks, Noah's Bagel is not going to be able to stay in business. This is just normal thing. So it's like, hey, look, if you want this opportunity, and if we want it as a community, we have to make a commitment, like a campaign to commit to delivering here. Would that, if you guys upped the number of deliveries that were done in the hospital, would that be a piece of it?
That would certainly help. Yeah. But I think it would have to go well beyond that,
Oh, sure. I'm not saying that's a silver bullet, but like if we had, okay, let's just start with the education piece. What is needed to get more labor? And do we need more nursing programs specializing in labor and delivery? Do we need to, make the Emmett area seem more attractive? Do we how do you solve part of that staffing issue?
Well, first of all, I mean, we have a nursing shortage across the board, just in our country. We're just not producing enough nurses to fill all the vacancies.
Okay. But Brad, you're a business guy, right? I'm an idiot. I'm a total idiot. Why don't we be like, okay, nurse, we're paying you people 60. You don't want the job at 60. How about 80? You coming in? Who's coming with 80? Like who's going to, or 80 is not good enough? How about 100?
Well,
but if we have a shortage, can't we just ratchet up the compensation?
Well, it's a supply issue.
I know, but we could solve the supply issue with incentivization, couldn't we? Like if you paid nurses $300, you would have so many nurses. They would be falling out of trees. They'd be like, I'm here. Like I would go like, just where's the application? Like sure. I'm going right now.
Yeah.
Is it that kind of thing? The reason I ask this is because there's a constant argument for teachers, right? Where it's like, we don't compensate teachers enough. And a friend of mine years back was like, I don't think that's true. I think what actually happens is there are plenty of teachers who would be happy that teachers are not going into the job to make a lot of money. People that are financially oriented or like really want to make a dump truck, they don't even consider teaching, right? They're just not. So she was like, the real problem is we're not getting rid of bad teachers and opening spaces for other teachers. Like, look, I don't know what the problem is, but her idea of what actually motivates that particular profession, that did stick with me, which is like, huh. And as an educator, I was like, listen, I didn't go into public education because I knew I couldn't make money. She was like, yeah, but you're not the average teacher. You went into private education because you had the burden of, being the breadwinner in your family and wanted that. It's not like I was fighting it. It's like, I want to teach, but I also want to make enough money to support a family. Mm-hmm. And she was like, and you're not that person. You're not the person who's like, I don't care. Like it's in my heart. So for nurses, what's the motivating factor? Like whatever it is, let's just give them what they want, or give the potential people that would go into nursing but select a different career. Let's give them. So it was like, no, this is better. Like this is the better option. Mm-hmm. We're like, what is that? What do they want? What motivates people, Brad?
Well, that's a whole nother can to open up. But
I'll
give you my thoughts. Yeah, for sure. And there are
today.
Really with my glass of tea, we're gonna get there.
I got enough black coffee. It'll keep me going till midnight.
Yeah. There are some great nurse leaders, doing really good work around this, but it's way more complicated, as you can imagine, than just saying, hey, we're going to pay every nurse $300,000. I think that would help. This is one of those where it's like, oh, well, if this, then this. And so one of the issues is faculty, and I'm not the expert. Maybe get somebody from BSU or ISU to talk to you about this. But if you take a nurse who's at the point in her career where she's, and I'm just going to say she, but there are also male nurses, right?
How sad?
I know. I'm so sorry.
I can't believe you.
So,
keep going.
She's in a point where in her career where she's making good money, and there's an opportunity to teach at BSU, and you get to be paid as a state employee at whatever rate they pay. That's one of the problems. Nurses look at that and say, or they can say, I could go to Amazon and I could work from home and I could make significantly more. I don't have to deal with patients or whatever.
Wait, what are these jobs you're throwing out? I want to go to Amazon. Like, I want to go to BSU. Like, are you saying the path to Amazon or BSU is through nursing? Like,
no, I'm just saying,
what are we doing
here? Those are competitive opportunities for nurses. So, one of the reasons that we aren't producing a lot of nurses out of our training programs is there isn't faculty there. One of the reasons we don't have faculty is it's not an attractive, from a financial perspective, it's not attractive to leave. Those nurses who have the experience, typically they're going to make more working where they are or taking a job at Amazon than going to work as a state employee at Boise State. And again, I'm not the expert. Talk to some experts, but that's an issue in and of itself. So we don't necessarily have a system in place to really produce. You could be standing at the end of the line saying, hey, I want to give somebody $300,000 a year, but they've got to get all the way through that. And there's got to be big, wide open gates of training programs, faculty to teach, opportunities to go do clinical rotations and all of those things. So that's a complete oversimplification of the nursing shortage, but we've got to do a better job as a country, like you were talking about, making it more appealing, and be, creating the pipelines to get those nurses ready. The thing for us is we have to have nurses who are ready to fill a really unique niche, like I described, that, you're gonna work in an environment where you're wearing all kinds of different hats, or you're not going to be a trauma nurse, you're not going to be a NICU nurse, you might be able to just be an ED nurse, but most likely you're going to have to work ED. You're going to have to work some on the medical surgical floor. in the past, you might have to get involved in delivering a baby. So, and that's just the nature of small organizations and rural care where you're wearing lots of different hats, but that's not for everybody. A lot of people like to just say, I want to be a NICU nurse and I'm going to grow up, or I'm going to work in the PICU. They're really
what's the PICU?
The pediatric intensive care unit.
Okay,
Sorry,
great.
we love our acronyms.
You love them. It's fantastic. You said like pancake earlier or something.
Yeah, sorry. But you've got to have a special type of nurse that wants to work in that environment. And I did a city club, a panel with Susie and some other folks, and we talked about what is good. We talked about a lot of things that were really problems in healthcare and things that we're doing to try to address those. The things that are good, nurses are a great example. Physicians are another example. Really, all the staff that are in healthcare, they're not there to make money. They're there to impact their community. They're really good people, and that's a lot of that is what keeps us going day after day.
Man, this is complex. So there's no quick solution to improve staffing shortages. There's no quick solution to encourage more people to utilize more local services. And there's absolutely no option for you to offer a half-hearted effort at this. It's not like sometimes we do plastic and sometimes we don't. It's like, no, we're 24 hours. Do you feel that I know some people, again, as start the conversation, some people have really talked about the legislation as driving out OBs from the state. Do you think that has affected Emmett to any significant degree, or do you think that it's something that's predominantly affecting other areas in the state?
I don't think it's affected us directly. We haven't had, that I know of, any nurses or physicians who've said, I'm out.
Sure.
I can't practice like this. But I do think that we've been impacted indirectly. So we're things that are happening in Boise and Meridian and Nampa, we sort of get a ripple effect of that. As an example, we had a relationship with the OBGYN group here in town that they weren't doing deliveries for us, but they would come out and do procedural work, particularly for ladies who are later in life and needed GYN support. Excuse me. The practice lost physicians. They lost physicians specifically because of the legislation. They can't recruit. They've had open recruiting positions or open recruitments for years that they're trying to fill. I met with one of the physicians who's a owner in the group, saying, I have to offer these new physicians coming out of training more than I make right now as the owner of the group, just to get them to town. And they're just not getting anybody. So the indirect impact on us is they've kind of said, hey, we've got to take care of our core responsibilities. And although we love to support the rural environment, we really enjoy in this position specifically, it's really meaningful, and talk about kind of that moral desire to serve others, for that physician to come into our rural community and help these patients was really fulfilling. But he said, we just can't do it anymore. I have to be kind of back at home base taking care of that core. So we lost that service. Again, it wasn't necessarily deliveries, but we lost that service as an indirect result of them losing physicians as a result of the legislation.
Man, how do we get more OBs here? Like, how do we do that? It's one of those things where the number of people I've talked to, like, wait, what's the solution? They're like, there is none. There's no solution. We're like, what do you mean there's no solution? It's like, well, we don't have residencies here. So if you are going through medical school somewhere in Idaho and you're like, I really want to be an OBGYN, you have to leave the state, go to your residencies, internships, and all that stuff outside of the state. And then, having seen the world and done all that, you have to elect to come back here. Okay. They're like, so that's the first problem. Every single person here, it could not be homegrown. They literally have to elect to come back. So that's first. I mean, I remember talking to a parent years ago about their kid going somewhere for school. And like, well, I don't really want them to go too far away because, people go far away and then they kind of stay there. They, they're 18 to 22, you know, the restaurants, the coffee shops, you're like, it's not too bad. You get a job offer. You're like, hey, I'll just hang out here in like Boston, wherever the hell you are. It doesn't matter,
Yeah.
right? And, so you have that level, but it's hard to get people in. And then we have a shortage of these other supportive aspects of it. We have poor compensation coming in from public reimbursement mechanisms. Like, Brad, what do we do? Like, where's the solution here to get more OBs in even in the absence of L&D emphasis? Like, how do we get them back? Because like my wife and I are most likely done with having children unless, some miracle happens. And God bless miracles. Great. But, like my wife needs to have medical care as a woman through the rest of her days. And I would like her to have sufficient and robust medical care. It's not, we do have some means, but I don't want her to be going out of state to have to just go see an OB for a regular thing, because the option here is like 3 or 4 months away. They're like, well, I just want a regular checkup. They're like, that's going to be 2025. She's like, what do you mean it's 20? Like, can't I, whatever, like what, how do we do this? Because I understand the problems. Like, people keep articulating the problems. Like, we have a certain degree of legislation. We have a certain degree of compensation, as you're saying. Like, we have all these, okay, how do we fix this? Like, do we just go to the insurance companies and say, hey, in order to provide this, we're going to have to charge you twice as much for, any OB stuff, because we cannot attract people to do the job in the absence of this. And the insurance companies will be like, dang, that stinks. And they'll increase everybody's premium by like $10 a year and pay for it.
We all pay for it.
Yeah. But that's fine too.
Sure.
Like, that's fine. Charge me $10 more per month and just make sure we have all of the people we need for the women of Idaho. Like,
Right.
Charge me, I'll tell you what, 15, charge me 15 more
I'll do
on a
that.
monthly basis
I'm
per
in.
person. Like, is it really that basic where it's like, okay, just dump money into making a residency, an internship, dump money into like 2 new nursing programs, dump money into paying them more so we can attract more people in the near term? Like, is it all of these things that we need?
Yeah, I think it's a whole bunch of different levers that you can push. To give credit where credit's due, the legislature did get it right. There was a significant increase in the amount of money going toward medical training programs, graduate medical education, GME, there's your acronym, in our state. Awesome. We could definitely do more, but, a training or a residency program that's specifically focused on OBGYN would be incredible. And I wish I had the statistics, but it's true. Where people train, they typically stay. If we can get those Idahoans, those, stars that are going to medical school and doing residency from Idaho, they'll want to stay if we have the programs. I certainly believe that as well.
Right. This place is great.
Oh yeah.
Yeah.
And I have 3 daughters. At some point they're going to want to have children, hopefully. Right. And I worry about that too. As a girl dad, I'm like, I feel bad about being in a state where their access to the care that they need is limited. And I think one of the things that really has to happen is those decision makers need to listen to the physicians. I feel like decisions have been made in our state that have not taken the input of the physicians, the ones who are there with the mothers every day, going through, the prenatal, postnatal care, the delivery, all of that. That's a voice that I don't think was considered in the decisions that were made. And then you start to see that, and you have physicians who leave because they're afraid to practice medicine the way they were trained. They don't want to go to jail.
Yeah, right.
And so that's one of the primary drivers. So I think if I'm not a legislator, I don't.
Yeah, neither.
I don't live in that.
I'm a nobody. I'm
Right.
a dude with a mic and a camera.
Yeah.
So don't listen to us.
But, I will just tell you as a leader, and a leader in an organization, when we need to make a difficult decision, we bring people to the table and try to get that input. As an example, I had a OR manager, operating room manager that, was trying to make a decision about, I don't know, some service or piece of equipment or something like that. And he's like, well, what do you want us to do? And I was like, Steve, I've never worked in a OR. I don't know. Like, you got to tell me.
I don't know what to do.
Right?
Yeah.
You need to tell me, and I'm going to ask you tough questions and, try to work on different solutions, and, we'll come to a good decision, but you can't ask me that. And so I feel like I'd like to see our elected leaders bring the physicians to the table who are living in that world to say, okay, we need to make the decision that is going to work here. And I understand there's differing opinions and all those things, but the situation that we've created right now is driving well-trained, well-educated physicians who are driven to serve people and, up until this point, driven to serve Idahoans out of our state. And that just, it's got to get fixed.
Yeah, I was trying to wrap my head around the different polls with everything you were just talking about a couple weeks ago. And it was interesting because I started realizing there are different people and different groups that are driven by different things. And it doesn't appear that they're talking or hearing it. The communication is poor. For instance, you have people that feel that the laws in Idaho should be derived from a certain philosophical standpoint, right? Let's say pro-life people or pro-choice people. That's a lot of people are like, philosophically, it's a woman's right to choose. Okay, I understand that. And then the pro-life people are like, hey, the defend life. Like, okay, great. And these are philosophical leanings, right? These are ideologies that are saying like, hey, based on this principle, we should take this action. These people are principled. And those are the people that, like citizens, that are putting pressure on, say, legislators to make certain laws. The legislators are driven by some degree of principle, but they also have an obligation to, one, I've never met an elected official that doesn't want to be reelected, right? Like they're like, okay, like, I got to work with my constituents. And they also have the burden of enacting legislation that people will participate in. And the thing I thought about that was so clear on this is like prohibition. People passed a law back in the day that the American populace was like, I'm not participating. I'm not going along with, like, I'm going to keep drinking. And if you don't let me buy the alcohol, I'm going to make it myself, or I'm going to buy it from some dude who's making it. We're going to set up establishments called speakeasies. We're going to have the birth of the mob, like all of these different things. It's like, we don't participate. So you have to, from a political standpoint, at least consider, I need to pass legislation that people will engage in. They won't break the social pact and just go out on their own. And, I know there's a lot of data around, like in the places that have made abortion illegal, what the increase in illegal abortions in the area and the risk to women's health and things of that nature, right? Like that's just a fact. So you have the principled citizens on one side. Then in the middle, you have the legislator. And then all the way over here on the other side, you have the medical establishment. And all of the medical professionals that I've spoken with are driven by pragmatic, disease-based solutions.
Yeah.
Right. And I absolutely recognize there are likely some people that left that also bled into the, ideological, like, hey, it's a woman's right to choose, and I'm not going to practice in this state because you guys philosophically, you and I, we don't line up. But the other people that I haven't spoken to, any of those people, the people I have spoken with are like, listen, the disease process does not care about your philosophical position.
Yeah.
The disease process also doesn't care about getting you reelected or care about what people are going along with. The disease process cares about no one. And we are tasked with saving lives as best we can. Because again, I have not spoken with a single physician who's like, no, I believe in pro-choice. In fact, Dr. Casper, who I spoke with, she's like, I've never done an abortion. I didn't do it in medical school. I have not done it in my practice. I will never do it. I do not believe in that. But she was also saying, but that doesn't mean that the laws we have in place work from a functional standpoint with what's going on right now. She brought up this great example because I'm a dummy. I didn't understand. She was like, listen, what do we do when I tell you we're increasing the risk of your wife having a stroke? Now, I can tell you, if you go from 1% to 2% chance of having a stroke, you probably don't care that much. But if we start going into the 50% chance of having a stroke, that's a problem, right? It's also this acute event that cannot be reversed. Mm-hmm. Once somebody has a stroke, and we're dealing with probabilities. Once somebody has a stroke, there will be damage most likely that will never be undone. Right. And it could end in death. The stroke could absolutely end in death. It may not. This person may just be, impaired for the rest of their lives. Like all of these things. And when she started breaking this stuff down, I was like, oh, Lord. Yeah, I don't know what to do. She was like, we never deal with absolutes. We're dealing with probabilities. And what the people that are dealing with principle and the legislators are attempting to do is make things black and white. and write out very clearly, this is what's okay and this is what's not okay. And she's like, but I have to live in the human world, and the human world doesn't care about any of that.
Mm-hmm.
And quite unfortunately, the first two groups all do not deal on a daily basis with the fallout like the medical group does.
Right.
Right. They're the ones that have to deal with the pain and the suffering, the disease of patients and themselves. They also, as somebody pointed out, they're like, if you're practicing medicine and you see somebody going, let's say they're increasing their risk of having a stroke, right? And you're like, listen, pre 2022, like we would have taken this course of action. Her risk of having a stroke or losing an organ or something is really increasing. Like this is really, really bad. And you don't act, you have to put your career and your livelihood and your experience in front of this person's health. And God willing, everything works out all right. But there are situations where people are like, okay, I did not act in the way that I was trained to act. And, I got a worse result.
Mm-hmm.
Like the bad thing happened. This just so complex with all these different groups and all the different fallout and, man, it's too much. Like my little pea brain can't conceptualize it all.
Well, it's interesting. I agree with all that. And the piece, and the physicians can speak to this more, but, not only are they in this situation, in all other situations where they're trusted by their patient, by everyone in their community to use their judgment, use their education to make decisions. And, so they're not only using their brain, but they're using their heart as well. I know this patient, or even if they work in the ED, they work really hard to understand the patients and make decisions that are consistent with what they've been trained to do. And you talk about pragmatic. I mean, what physicians have been trained to do is based in evidence. Their whole training program is, in this situation, we've learned over time and we've studied, we've done research, this is what works. And so I don't know if anyone has ever articulated it, but I feel bad for the physicians because, that sort of relationship collateral, that trust, they're in a situation where they don't have that, like you said, elected leaders have made it, black and white, but it's not a black and white situation. And they've got to make, like I said, in all other situations, they're able to make these judgments and use their experience and use what they've learned and do the best of their ability to take care of that patient. And I think that's one of the biggest things that's difficult in this situation, where it's kind of like, well, I know what I would have done before 2022 based on my training experience, but I can't go there. And that's, I got to believe that a lot of that is, what has driven OBs out of the state. And frankly, the vacancies, the time that it's taking to even get people to submit a resume to come to the state is just...
Is that a problem nationally? Because you were talking about a shortage of nurses nationally. Is that a problem that other hospitals are experiencing, where it's like, say you go to, say, a very pro-choice state, right? Like California or Washington or Oregon, right? Are they experiencing a similar lack of supply of OBs willing to come and practice in that area? Or is this kind of like a conservative ordeal in conservative states?
So I don't know the data.
Okay.
And we're talking nurses and physicians. I'm talking
right.
About,
these are different things, right?
So physicians specifically, I can only speak to, the conversations I've had in our state with, health systems and OB practices who are saying, yeah, we can't even get somebody to send us a resume. They're just not interested in coming here. They don't want to practice that way. So, if there's somebody who is interested in moving to the Northwest, they might be more interested in, practicing in a state that allows them to practice medicine the way that they've learned and trained and, what they feel is the right thing. So,
right. And I think it really, like, if it's not clear, like, I'm not advocating for specific I don't think you're advocating for specific policy. I very much believe that, one, I do not have the answers, but we will not collectively figure out the answer unless we put all the problems on the table. And understanding all of the individual problems, including staffing shortages, financial compensation, all of these things, we will never find a solution to having robust, women's healthcare here. And that's concerning to me because I don't hear a lot of like the things you've told me today. I have not heard before, right? Like there's one guy on TikTok I used to follow years ago, and it was this is a doctor something or other, I don't know. And he was really good at making content. He would always do these mini skits where he'd be like have a headband and a pen coming out like he's a call center explaining insurance. And some of the skits he was doing were like residencies in rural hospitals, and it would be like the like old seasoned doctor here with a pen. He's like, the farmer came in, and the guy's like, yeah, I don't know. Like he was like, what was he doing? He was like, he was working on his fence. He's like, well, did he finish fixing the fence? They're like, no, he didn't. He said he had chest pains. They're like, oh God, get the jumper cables. He's going to code right now. Yeah. Like the farmer left. Right? Yeah. And again, he's like, just slap him up on the folding table and like shock him with a battery, right? Like, because you're just stretching your resources to try to serve the community that's also stretching their resources and trying to just get on with life. And they're also tough as nails and, might wait till the last minute. I have a friend who literally lives across the street from me, and he does plastic stuff and some other things. And he said that a farmer came in whose entire right arm had been degloved a month prior. So degloved is literally the scene from Terminator when he cuts his wrist and rips the skin off. So this guy had lost his entire skin, all the skin on his arm, and he had wrapped it up and carried on for a month. And like he finally came in, he's like, this is really hurting. They're like, okay, let's see what's going on. Oh, God. Hang on. And then they're like, and they took care of the cadaver skin grafts and this whole thing. But like, he was like, it's a miracle the guy didn't get some ungodly infection. They'd ripped off the entire barrier between his, underwork. Like, anyway, so I understand that there are problems in rural hospitals, but I've never heard these things. And it's like, man, if we're going to provide, one of the beautiful things about Idaho is that it's more rural and people move here because they enjoy that, but then they expect the services from like a huge metropolitan area.
That's a challenge. Right. Definitely. Yeah. And you asked me previously, what are we going to do about it? What are the solutions? And I
definitely keep asking you that. I definitely
like, we've got to get everybody at the table. And I love that, your platform is all about communication. Yeah. I would love for the physicians to be at the table to help come to a solution. And I'm not necessarily advocating for one side or the other.
Right. Let's find a solution, whatever it is.
Best decisions when the stakeholders are at the table and able to communicate openly with each other and have, I think that we have mutual purpose. I think that regardless of where you stand on the issue, we want, like you said, we want great healthcare for women in our state.
Right. I think I'm taken care of. I think you're taken care of. That's the goal. Healthcare for your daughters, for your wife, for my wife, for my boys' wives, if they are so lucky to get married. And like, let's start. That's the target, guys. Let's all come to the table. The principled philosophical people, the politicians, the medical practitioners, let's all come to the table and hash this out to find something that gives the best opportunity to attract and retain health professionals, that gives the best opportunity for the citizens of Idaho to participate, that honors the wishes of Idahoans from a philosophical or theological standpoint, like whatever it is, let's find a solution. And we will not do that if we're just screaming at each other. Like one side's like, they just want to kill babies. And the other side's like, they want to subjugate women. It's like, okay, what if neither one of you are right? Like, I've never met somebody who's like, I just want to kill babies. Like, that's not fair. And I've also never met a conservative person who's like, I want to subjugate women. Like, I don't know if you've ever tried that. It's not that easy. Like, go ahead and try to like push down on, like, it doesn't work, right? Like that's not reality. The reality is it's complex, and we're all going to have to take a deep breath and come to the table. Not me, because I don't do anything, but like the people that know how to do things is like, come on, man, let's do this. Like, let's find solutions. Idaho has always seemed like this beautifully pragmatic state that's like, look, we don't have a lot. We're trying to solve problems. We're trying to make life easier on people. Like, let's do that.
Yeah, let's work together.
God bless it. Brad, listen to me. I appreciate you. You came in. We had not met each other here. We had a great conversation. Is there anything you want to say here at the end?
It's a pleasure. I appreciate you bringing light to this issue in the state. It's big. It's important. It impacts our community, our organization. And like I said, my daughters, my wife and I have 3, and this is a big issue for us. And I've lived in Idaho my entire life, and I want to see us, come to a solution that's going to meet that mutual purpose that we talked about. So
Yeah.
thanks for the opportunity to share my thoughts.
Yeah, man. Listen, God willing, I'm in it for the long haul. Everybody saw in the election how powerful the podcast media has become, right? And these are people that started these things years ago and just worked to be real with people over and over and over. And it cut through so much of the BS and allowed people to see individuals they're voting for in a way that has never happened. And if we can apply that type of communication to the state of Idaho, we will never attract those people because Idaho's too small. Like, we have under 2 million people. We are never going to get somebody who engages in a national platform to come and focus solely on Idaho, but we can have one for Idaho. And God willing, man, like, that's what I'm trying to do. And so your participation and explanation of an Idaho-centric issue, trying to solve problems for Idahoans and trying to bring people to the table, I just really appreciate you.
No, thank you.